Okay, so this is the adult deformity and Corder-Quiner syndrome paper session 3. So we'll get started first with Chinedu, if that's okay.
Hi, good morning all. My name is Chinedu Egu. I'm one of the trauma orthopedic registrars. I'll present our paper on CT Hansfield units as predictors of spinal outcomes, post-instrumentation. It's a systematic review and meta-analysis. These are the authors. I'm affiliated to the Queen's Medical Center, Nottingham University. We know spinal instrumentation is utilized to stabilize and align the spine. There are complications with this. Mechanical complications include cage subsidence, pedicle screw loosening. We also have proximal junctional kyphosis and failure, and we also have pseudoarthrosis. We all know bone mineral density is very important for determining if the spine instruments would fail or not. Low bone mineral density has been measured over the years with DEXA. However, there are pitfalls with this. It overestimates bone mineral density in spondylosis, dish, ankylosing spondylitis, in vertebral fractures or vascular calcifications. CT Hansfield units has come up as a routine perioperative, around perioperative scans. It has been shown as a promising alternative to this because it reliably measures bone mineral density. What we tried to do was evaluate the predictive role of CT in actually predicting these outcomes. We followed the PRISMA guideline, 3 databases. We included papers that included adults who had spinal instrumentations, and they correlated their outcomes with Hansfield units. They were all English studies. These are PRISMA charts. We identified 1,130 papers. We included only 35 that met the inclusion criteria. And these are the results. From the cage subsidence group, we had 11 studies. We have 1,114 papers. The patients, the incidence was 35.5%. Hansfield units were measured from the L1 to L5 vertebral body, and the cutoff threshold to predict cage subsidence was less than 198 Hansfield units. In the pedicle screw loosening group, we had 14 papers, 2,102 patients, 27.9% incidence of pedicle screw loosening, and the Hansfield units were measured from L1, L4 vertebral body or the L1, L4 screw trajectory region. And the Hansfield unit cutoff threshold in the vertebral body cohort was less than 116, and in the screw trajectory cohort was less than 119. In the proximal junctional failure group, we had 9 papers, 666 patients. The incidence was 28.6%. The Hansfield units were commonly measured from the upper instrumented vertebra, and the cutoff threshold to predict proximal junctional failure was less than 151 Hansfield units. Now, the pseudoarthrosis group was just 1 paper of 45 patients who looked at Anderson D. Alonso type 2 and 3 odontoid fractures. They measured the Hansfield unit around the odontoid process, and the cutoff threshold to predict pseudoarthrosis in patients who had odontoid fixation was less than 260 Hansfield units. There were limitations. It's a small number of studies. They were retrospective. They were not randomized. And then there was heterogeneity in the measurement of Hansfield units among the papers. It's reduced our ability to actually make a very strong conclusion. But what we can say here is that lower Hansfield units strongly predict poor spinal outcomes. To predict screw loosening in the thoracolumbar region, it's less than 130 Hansfield units. To predict cage subsidence in the lumbar region, it's less than 200 Hansfield units. To predict proximal junctional failure in the thoracolumbar region, it's less than 150 Hansfield units. And to predict pseudoarthrosis in those who has odontoid fixation in the cervical region, it's less than 260 Hansfield units. From our paper, measuring Hansfield units from your operative segment has been shown to be a very reliable preoperative risk assessment tool. Thank you.
Thanks very much, Chinedu. Should we open it up to any questions? So, Chinedu, in terms of actually measuring, sorry, it's not a planted question. I know I'm the senior author on the paper, but we haven't actually spoken about this. Where would you want to measure the actual Hansfield unit from on the vertebral body? Does it make a difference?
Yeah, so they found that it's actually within the vertebral body itself, and excluding the cortical aspect of the vertebral body within the cancellous segments. And I had a picture up here, if I could go back, where you'd see, you could use your common imaging system like PARCS, and a circular motion through 2 seconds. So just creating that circular halo around those cancellous region of your vertebral body would help you detect a proper Hansford unit around this vertebra.
Great, and presumably you're going to need a CT scan. There is
CT scans, yes.
Is there any other way that we could measure without getting a CT, for example, from an MRI?
From an MRI, no. We didn't look at studies looking at MRI scan, but CT scans, the good thing about it is that it's not an extra cost. It's a normal imaging we require for preoperative assessment. So those CT scans, you don't need to send the patients for extra radiation, really helps to detect Hansford units.
Okay. Sorry, go on.
Thank you.
Very quickly, you said the Hansford unit is around 200, less than 260. That seems to be quite high.
Yeah.
Because the osteoporosis, which is given in the papers, for osteopenia for a definition, and an opportunistic use of qualitative in quantitative CT is less than 130. For you to call osteoporosis, it's 90, but you're quoting at 260.
Yeah.
How do you, especially is that because the case subsidence as well is 190 or 200 pounds per unit? Because are you worried about the end plate which you are mainly worried about in the case?
Yeah. Thank you very much. So the paper is PICAD in 2013, where they actually sort of talked about osteopenia being less than 130, osteoporosis being less than 110. However, what we tried to do was, what's the Hansford unit at which a spinal instrumentation will fail? The problem with pseudoarthrosis group in our study is we only had one paper. They only looked at the cervical region. They only looked at odontoid fractures. And these were where they extrapolated their figure from. So it was just that one paper that we could extrapolate from. But the good thing is that we've got good, good conclusions for the lumbar cage subsidence group, there's the pedicle screw loosening group, and the proximal junctional failure, because we have a good number of studies in those papers. But the good thing about the study is you could then say, okay, there is a paper on cervical odontoid fixation that this is the value. So that could guide you. It's all about clinical guidance for our decision making. Thank you.
Thanks very much. Thank you, Sinead.
Thank you very much.
So we'll move on to paper 27 by Ahmed Hassan.
Good morning. My name is Ahmed Hassan. I'm a spinal surgery fellow at the Center for Spinal Studies and Surgery at Queen's Medical Center, Nottingham University Hospitals. And our talk today will cover the use of enhanced recovery after surgery protocols in adult spinal deformity. With a meta-analysis, are they effective? This is my conflict of interest disclosure. So as an introduction, the prevalence of adult spinal deformity has gradually been increasing over the past years, making it a major health concern. Especially those vulnerable group of patients have high risks of complication, prolonged hospital stay, and increased health care costs, which makes the implementation of the ERAS protocols in these patients a very valid option in order to reduce the surgical stress response and improve their postoperative recovery. So we aimed at conducting a systematic review and a meta-analysis to evaluate the available literature on the application of the ERAS protocol in adult spinal deformity patients, with a special emphasis on the effectiveness on special emphasis on some outcomes such as blood loss, length of hospital stay, and post-operative complications in a trial to formulate a standardized ERAS protocol for this group of patients. So we conducted a systematic review according to the PRISMA guidelines. We included patients with adult spinal deformity. We only included articles that implemented a full ERAS protocol. It was a 3 phases, pre, intra, and post-operative phase. Only comparative studies was 2 arms, one was an early recovery, and the other arm is just conventional surgery. We excluded non-English articles, review articles, and articles which included in their study population other spinal pathologies such as post-traumatic deformities or infections, and studies with less than 3 levels of spinal fusion. We conducted our research on 3 databases, PubMed, Web of Science, and Cochrane Library. We used the GBI critical appraisal checklist for non-randomized trials as a risk of bias assessment tool. We used Rivman for the meta-analysis utilizing a random effect model. For the results, we finally included 5 articles after our literature review. The main cause of study exclusion was heterogeneous study population, including other non-degenerative causes of spinal deformity. For the study characteristics, all of the 5 studies were retrospective in nature. Both arms were more or less comparable in their baseline characters. For the risk of bias assessment, all of the 5 studies had a low risk of bias. And we were able to pick up for the qualitative assessment, the most important features of the proposed ERAS protocol for the preoperative phase. It mainly included patient education and counseling, having an aesthetic review, nutritional assessment, management of osteoporosis, stopping smoking and alcohol 2 to 6 weeks preoperatively, and chronic pain team review if needed before the surgery. While during the intraoperative phase, it's recommended to have a dedicated surgical team using TIVA as the anesthetic modality of choice, using different pain management techniques, routine use of TXA and cell saver, routine use of power tools, and attempted extubation in all patients. If failed, they should be transferred to ICU. The only controversial aspect in this phase was the induction of hypotension, where 2 studies recommended inducing hypotension to a MAP of 65 during the approach, while the other 3 studies recommended against it, just keeping a MAP above 85. For the post-operative phase, also multimodal analgesia, early removal of catheters and drains, preferably at post-operative day 1, early ambulation and oral intake from day 0, and incentive spirometry. For the quantitative analysis, the meta-analysis itself, we showed there is a significant, statistically significant difference when it comes to blood loss, hospital stay, and post-operative ambulation, all of them favoring the ERAS protocol comparing to the conventional surgery. However, we couldn't find any difference between the 2 study arms with regards the reoperation rate, complications, perioperative blood transfusion requirements, or the operative time. So in conclusion, we were able to pick up the main points of each of the ERAS protocol for each phase of the surgery in an attempt hopefully to formulate a full ERAS protocol for these patients. The use of ERAS protocol has a significant reduction in the length of hospital stay, blood loss, and postoperative and earlier postoperative amputation, and there is no significant difference when it comes to either complications, reoperation rate, perioperative blood transfusion, or operative time. Thank you.
Thanks very much, Ahmed. Any questions? So Ahmed, you've recently started working with me on my firm, yes, and you're going to be with me for 6 months, and you've done this really nice work on ERAS and these protocols. After you leave, how am I going to implement this?
Okay. So we'll try to hopefully to formulate a standardized protocol that can be implemented, started with the preoperative phase. I know some steps are routinely taken, like for example, assessment of osteoporosis and evaluation of getting an anesthetic review before the surgery, but it should be formulated in a standardized protocol, especially for the post-operative phase.
Yeah, no, so what I'm asking is that how do I go about getting buy-in to implement ERAS into the service? How can I get people on board to implement this? How would we do it?
So the main convincing point for me is that it will, the strength that it reduces the length of hospital stay. So this is the main cost issue So especially with this group of patients, they have very prolonged hospital stays. So there is the best point that we can focus on, that it reduces the length of hospital stay.
Yeah, exactly. So you're looking at your indicators, what you want to measure, and then you usually do a small pilot study, maybe 5 or 10 cases, probably through a PDSA cycle, Plan, Do, Study, Act. You implement a few of these measures, see what happens, and then you do another cycle with more measures implemented, and slowly you build it up. But you need buy-in, you need to be collaborative with all stakeholders. Anything else? Okay, thanks very much.
Thank you.
Next speaker, Damien Kimber.
Hi everyone. Can't see anything on this screen at the moment, so I'm just waiting for a second rather than turning around all the time. Is there anything going to come on this little screen here? Thank you very much. Right, so hi everyone. My name's Damien. I'm a consultant physio working in a spinal triage service down in Birmingham. I'm going to talk to you today about my qualitative study into cauda equina screening with the Pakistani community. Okay, this isn't moving. I have no conflicts to declare. So, as we know, cauda equina syndrome is rare, but it can be a spinal emergency if decompression is required. Existing guidance has well documented what questions we need to ask and the way that we need to ask them when screening for this condition. So previous work, which you can view if you want to by scanning the QR code, revealed that physios believe there to be barriers to effective screening for cauda equina caused by language and culture in non-English speaking patients. And to date, there's nothing published in this area. So analysis of demographic data from my musculoskeletal service showed that after white British, the next biggest ethnic group is Pakistani. So my aims were to explore the process of cauda equina screening from a cultural and linguistic point of view, using interpreters as a conduit within the Pakistani culture. And I purposefully sampled and interviewed 12 Pakistani interpreters and then subjected the transcript data to thematic analysis. Busy slide. So we extracted 5 key themes with a number of sub-themes, and I'm going to elaborate on a few of them now. So society and culture describes how cultural and societal factors impact how easy it is for interpreters to translate cauda equina screening questions. For example, cultural nuances such as the importance of modesty and the fact that sensitive and taboo subjects like sexual function are rarely discussed in Pakistani society. Issues around gender of the patient, the interpreter, and the healthcare practitioner, and how it would be not normal or acceptable within Pakistani culture to discuss these issues of a sensitive nature with those of the opposite sex. It's evident that most Pakistani patients would prefer same-gender interpreters where possible. Where not possible, simply having another person of the same gender present in the consultation, especially for female patients, will likely put the patient more at ease and may allay the gender barrier. The second theme, language barriers. So the fact that in some Pakistani dialects there are no verbatim translation of words like vagina or erection. Another interesting point was that participants said that often patients will say that they speak Urdu because this is the universal language of Pakistan. However, their actual mother tongue may be a different dialect. And so this has the potential to implicate their understanding of your questioning. So the patient's educational background is the next theme, and there's a lot of crossover here with theme 1B, which is the region that the patient comes from. So people from more rural communities, often in the north of the country, are less likely to have had access to or engagement in formal education, and therefore some of these words are less likely to be understood or even known by patients. So my fourth theme is suggestions to improve practice, and this includes universal agreement that providing supporting materials for patients informing them of the nature of the Cauda-Equina screening questions would help to make the screening process more effective. Finally, the role of the interpreter must not be underestimated, and the study provides practical advice regarding the interaction between healthcare practitioner and interpreter. So this is the first known study to look at the cultural and linguistic issues of Cauda-Equina screening within the Pakistani ethnicity. We've identified several opportunities to improve clinical practice and think that this new understanding will have directly transferable impacts on patients and clinicians involved in Cauda-Equina screening. So my take-home messages to you are to respect cultural differences and use softer, more modest language, specifically when asking about genitalia and sexual function, to use your interpreter's knowledge of their culture and language as a resource, to make sure clinicians have training on how to engage effectively with interpreters to get the most out of non-English speaking consultations, and then to consider providing supporting materials for patients relating to Cauda-Equina screening and the content of the screening, preferably in advance of their appointments. Thanks very much.
Any questions for Damien? If you'd just like to come up to the mic.
Thanks, Damien. Really nice study. Just one point to clarify, your interviews were with the interpreters only, not
Yes,
patients.
interpreters
Okay.
only.
And just some thoughts about your supporting materials. What might you suggest, or is there work in progress?
Well, there's no work in progress. That's next steps. The supporting materials that they were talking about were maybe including some stuff in the appointment letter that would maybe like a QR code that could take them to a landing page on the website that might explain the sort of things that you're going to ask them during an assessment, possibly in lots of different formats, because we know that literacy is an issue. We also know that some of the existing materials and the translations on the internet that are also already available are not very good. So that is a work in progress. Thank you.
Thanks, Damien. My name's Neil Robinson from Glasgow. What training did you have with the physiotherapists and interpreters?
Well, what training do physios have?
Yeah, to use the interpreters
None.
efficiently.
That's the point. So the physios that in Birmingham don't have any formal training on how to use interpreters, and how to engage with your interpreter is not just something that you know. It definitely requires training, and that's one of the findings. So interpreters often didn't have medical specific training, or if they did, they had forgotten about it. But equally, clinicians have no training on how to engage and interact with interpreters, and it's quite a complex interaction that definitely does need training. So this is something that needs doing better if it's not being done.
Thank you.
No problem.
We're encouraged to use telephone interpreters due to the reduced cost. Did you look at that at all? Could that actually improve things?
Yeah. So some of the interpreters said that it was much easier to do this on the telephone because you're not seeing the patient face to face. And so the societal issues about not talking about these kind of sensitive issues in person are sort of negated by doing telephone interpretation. So that is quite a good recommendation.
Thank you, Damien.
Thanks very much.
Next speaker, Ahmed.
So my presentation about Cauda-Equina syndrome and how to improve referral from GP. So first, did you know Cauda-Equina syndrome? This paper has been published by NHS Resolution in July 2020 about how much claims cost NHS over 10 years, and a huge number and age range of claimants and what is the causes, delay in specialist referral, diagnosing symptoms, MRI scanning, responding to red flags, surgical intervention, and transport. So National Suspected Code Equina pathway came out on February 2023 and give a clear triage criteria for referring the patient from primary care, then secondary care up to surgical intervention and post-op care from this collaboration of prestigious association and society. So in my talk, I would be concerned about primary care presentation, triage, and emergency referral. So from February 23 up to February 25 update, there is no much update on the primary care except onset of symptoms equal to 14 days. So after presentation, triage, which is the first step, and there is a clear symptoms and signs within 14 days and deterioration of symptoms. So GP should refer the patient as an emergency with emergency MRI provision. So in referral should be nearest hospital, MRI facility available 24 hours, and also telephone assessment could be accepted. This is what most important one, emergency referral documentation. These are specific points should be fulfilled before referring the patient to secondary care. So our methodology, we collect patient referral from a GP over 4 months. We analyze red flags, duration of symptoms, MRI finding, and the outcome, and we document this one with patient demographics. We collect around 47 referrals, 26 mostly females, and the age range from 27 to 93. We could find that 18 patients only has symptoms within 14 days, and 3 patients totally has no Code Equina red flag symptoms. We request MRI for about 40 patients as an emergency and urgent. We do find only 2 patients has radiological Code Equina compression and has been operated. So by conclusion, still GP referral as emergency should be much more improved. And we do recommend that maybe we need some enhanced GP training meeting. GP should be involved in ICP, referral pathway like on-brain referral or a fixed pro forma for Code Equina, suspected Code Equina. GP access to imaging, we could feel that the GP should be authorized to have access to urgent MRI slots and directly send the patient to MRI. Clear communication protocols like direct phone call, dedicated email address, and lastly, audit and feedback. Thank you.
Thank you, Ahmed. Any questions from the floor?
Alistair Hudd, Ipswich. We're quite lucky. We have a really good single point of access across our network generally. Despite this coming in 2 years ago and despite a lot of collaboration, I had to have a meeting with the ICB and the GP Fed essentially, who seem to be completely unaware of this. And we've had multiple people being referred in with incontinence as their primary thing, and out there still in the non-stakeholder, as in our non-allied health professional network there that are not commissioned by the ICB, incontinence is being used as the trigger for sending or for picking up the phone and referring these patients. I think it's important for those out there, because we've had this problem, and I'm sure it is out there in the rest of the country, that the triggers for the emergency referral are not incontinence. It might be worthwhile putting them back up again to show what are the triggers, because they are, incontinence is still being used as a single use, pull the trigger to pick up the phone. And there are a lot of patients, many of them get very upset because they know they've not got Code Equina, they've got something else. They know they've got something else. We've had diarrhea sent in from a bloke who went on a stag party, and the rest of the crew all had diarrhea because they'd all had the doodahs. Was sent in with query Code Equina because he'd had an episode of diarrhea. So, can I implore those who are out there in primary pathways just to reaffirm that both with yourselves, your colleagues, and with your GP partners, not to send someone in with incontinence unless it is associated with some of those other triggering factors. Thanks.
Any comments on that, Ahmed? Any further questions? Thank you. Next, Matthew.
Hi, my name is Matthew Morgan. I'm a medical student at the University of Southampton, and this is my presentation on the new UK suspected Cauda-Equina syndrome pathway. 1 year on, how is it working? There are no conflicts of interest. Cauda-Equina syndrome is a rare but devastating condition which, if not detected quickly, can result in permanent bowel, bladder, and sexual dysfunction. In February 2023, a new national pathway for diagnosing and managing suspected Cauda-Equina syndrome was introduced. This pathway aimed to improve patient outcomes, reduce litigation, and address unwanted variation in patient care. Recognizing the key role physiotherapists have in managing patients with suspected Cauda-Equina syndrome, this service evaluation sought to explore their perspectives of how the new pathway was working. This service evaluation took place in a community musculoskeletal service in the south of England. Data was collected via focus groups, which were chosen to allow participants to explore the issues they perceived to be the most important, and reflexive thematic analysis was used to analyze the data. The sample comprised of 13 spinal specialist physiotherapists, all of who worked in the service. The focus groups lasted roughly 1 hour, and 3 key themes were identified from the data. The clarity and consistency of decision-making, a lack of confidence in the ED's approach, and the potential for patients to get lost in the system. The first theme was clarity and consistency in decision-making. The new pathway was perceived by physiotherapists to provide welcome clarity about which patients required emergency referrals due to the introduction of the new 2-week rule. This clarity enabled physiotherapists to be more confident and consistent in their decision-making process and was perceived to reduce the number of emergency referrals made. Conversely, the new 2-week rule was perceived to oversimplify the messiness of day-to-day practice, where patients were not always sure of the duration of their symptoms or whether they were deteriorating. The rigidity of the 2-week rule therefore compromised the physiotherapist's ability to use their clinical acumen when deciding whether a patient required emergency care. Furthermore, for those patients with static Cauda-Equina syndrome for more than 2 weeks, physiotherapists were only able to access routine MRI scanning rather than urgent MRI scanning, with this therefore being inconsistent with the pathway guidance. The second theme was a lack of confidence in the ED's approach. Physiotherapists identified that it could be difficult to make contact with the orthopedic registrar, and also identified instances when the care in the ED appeared to be misaligned with the pathway guidance. Examples of this include a bladder scan alone being used to exclude Cauda-Equina syndrome, and often not scanning the cervicothoracic spine when lumbar imaging had excluded Cauda-Equina syndrome, but the symptoms remained. The third theme identified was the potential for patients to get lost in the system. Patients were discharged from the emergency department after Cauda-Equina syndrome had been excluded, but without any plan for follow-up, despite further investigations being indicated. Furthermore, referring clinicians were not informed of the outcome of the ED consultation, and the GP discharge letters did not identify the need for onward referral, for example, to incontinence services. These issues created a situation where patients could get lost in the system without follow-up or further investigations for their symptoms. So in summary, our findings suggest that in this musculoskeletal service, the pathway has provided clarity and consistency of managing emergency referrals, but the issues remain with how to best manage urgent presentations, and with how patients are managed both in and beyond the ED. We suggest 3 key implications. First, there is a need for further pathway guidance relating to how urgent presentations should be managed, including recommending timeframes for urgent imaging. Secondly, we suggest the need to explore the perspectives of ED clinicians to look at how the pathway is working in the ED. And finally, we suggest the need to ensure that the ED discharge summaries are available to the referring clinician and that they identify on the ED discharge summaries if there's need for further investigations or onward referral. Thank you very much. I'm happy to take any questions.
Any questions for Matthew? I have one, Matthew. You mentioned that the referrers would like the ED to follow this up, or surely it should be the referrer that follow. If it's not chorda equina, then it's a referrer issue, not ED's issue.
Yeah, well, some of the problems were that the referring clinician often doesn't get feedback from the ED consultation. So they can send this patient to the ED and effectively not know what happened unless they themselves ring the patient up in a few days. So it would be, I think, from the focus groups, I think what was identified was that it could be helpful if some sort of the plan was just maybe a sentence in the ED discharge summary, just to make sure that these patients weren't sent away from the ED, not knowing what to do, and then not being followed up for their symptoms, which presumably remain.
Great. Just to clarify, what we do in our service is that the referrer phones the patient 2 days afterwards, and then they find that, and we're lucky that the information is sent out.
Yeah. Sure.
Next question.
Thanks. A really interesting presentation, thanks. I'm interested in the first point with your implications slide there about the urgent presentations and how to refine that pathway. I would agree with you. I think that's a bit of a problem at the moment, and wondered how you're going to take that forward.
Yeah, that's probably the next steps. I think so looking at the time frame for for scanning as part of the urgent pathway, I think that could be looked at because, as I said, in this NHS trust, the physiotherapist didn't have access to decide when that scan took place. So it was just a routine scan, which could take anywhere upwards of sort of 6 weeks, which then you have to argue is that sort of an urgent scan. So maybe looking at introducing specific timeframes regarding when those scans should take place.
Yeah, because I think in the chorda equina document it says it's at the clinician's discretion, doesn't it? So
so it says they're at the clinician's discretion, but then if they don't have the ability to order a more urgent scan, then they're not able to follow that guidance. Yeah.
Just one more question.
Well, thank you very much for the presentation. In fact, you raised very interesting points. The problems we have with chorda equina syndromes are all the symptoms are very subjective. And therefore, this sometimes can leave the GPs to be very feeble because this is a very litigious type of a condition. And in addition to that, we have this unreliability or the lack of reliability in our system. So perhaps the question is, how can we boost the confidence in GPs and primary carers to adapt this pathway so they are more they have confidence to follow it? Because as the previous presentation, basically, I think we get a lot of referrals for incontinence. So in fact, we become the incontinence service here, mainly because of this sort of fear of litigations and also because of unreliability of symptoms.
So how to refine the pathway so people follow it more closely. Sorry.
I'm sorry, I'm going to have to call it there.
Okay.
Thanks, William Matthew.
Sorry. Thank you.
Next speaker, Emmanuel.
So, hello everyone. My name is Emmanuel Bourrigo, and I'm a PhD student in my 4th year at the University of Oxford. And my work consists of developing automated machine learning methods to understand scoliosis in 2D and 3D. And in this work, I'm going to present the 3D spine estimation from a 2D DEXA that has been presented at MICA conference. So the objective in this work is, given a DEXA scan, we want to predict the 3D global shape of the spine. And this consists of an image-based regression network that takes in a DEXA image and outputs two orthogonal projections, the coronal and the sagittal projection. And given those two projections, we are able to reconstruct the 3D spine shape. Now, the interesting question is that, is the network able to infer the sagittal projection, given that it hasn't seen it in training? So it only sees this DEXA anteroposterior. And we see here 3D spine rotating, so this is the output we want to get. And we learn these 3D curves given these paired data sets from the UK Biobank that we have access to, of more than 48,000 scans of paired DEXA and MRI of the same patients. And from past work, we already have a segmentation of the spine on the DEXA and separately on the MRI. So we are able now to align and register those scans. And this consisted of a two-step process where we did a first coarse alignment using automated machine learning methods involving common rotation translation matrices, but then we discovered that the spine themselves were not properly aligned, so we used the spine masks we had access to align the spine from the two modalities. And I'm showing here the splits because when we do machine learning method, it's important to test on unseen data sets if the model is performant. And I'm summarizing the annotations that we have. So to remind, we have already the spine segmented on 2D, on the DEXA, and on 3D. And so I'm showing here an animation. So these are the outputs of our model. We regress those three curves, so the middle curve and the two curves bounding the spine on the coronal and the sagittal plane. And once the network is able to estimate those curves, we can reconstruct the spine globally by fitting ellipses along the spine from top to bottom. And you see the spine rotating around the z-axis. And we validated these reconstructions against manual labels that we have. We did metrics of intersection of a union, so the overlap of the masks from predicted to ground truth, as well as the deviations of the centroid of the spine, so through root mean squared error. And we observed that the model is performant at the pixel level for the coronal plane, and for the sagittal plane, it's about 2 pixel difference, which is 1 pixel is 2.24 millimeter. And so we see that the model works for severe scoliosis spines, and it works also for normal cases. So here, similarly, given an unseen DEXA scan at test time, the model outputs coronal curves and sagittal curves, and we are able to infer the 3D spine shape. So to conclude, this work gives a patient-specific representation of the spine, because usually you would need a template, or people would use statistical shape models to reconstruct the 3D spine shape. Here we only need one DEXA scan. And we also avoid the cost of a 3D MRI. And this could have an impact in improving multi-view visualizations and more tailored treatment to the individual. And future works would include studying torsion, rotation of the spine, and the severity in 3D. And that's it for this first presentation.
Thank you very much, Manuel. For the interest of time, should we move on to your second talk as well? And then we can maybe take a question or two.
Happy to answer a question afterwards.
Yeah.
So this is a work in collaboration with colleagues in Bristol, Emma Clark and Jeremy Fairbank, is a spinal surgeon that's also greatly helping us in this work. And we are interested in the automation of scoliosis measurement on DEXA scans. So as a background, scoliosis, if it's left untreated, it may require invasive surgery and some long-term back pain. And as for now, most studies have focused on adolescent idiopathic scoliosis, but few have looked at adult cohorts. And with the UK Biobank, we have access to these large data sets of adults from 40 to 80 years old. And these are mainly degenerative scoliosis that have seen to be associated with disc degeneration and vertebral body collapse. So I'm presenting now the DSM method, which is the DEXA scoliosis method that we try to automatize. It's essentially a modified Ferguson method where we draw the lines from the shoulders and the vertical line to be able to estimate the maximum angle of the spine. So this consists first of finding the apex and then sliding along this vertical line to find the edges of that triangle. And we are trying to reproduce this process by humans automatically. So here you have a bit more annotation. So we are trying to estimate the triangle ABC on this scan. And so this consists first of finding the normal spine line, like human did, and then using a segmentation network to be able to identify the apex of the spine, and then point AB to reconstruct this triangle. So this involved standard segmentation network that in this case outputs body part segmentation, and out of the spine segmentation, we extract the midpoints. We see that they are a little noisy, so we do apply spline approximation to obtain smooth predictions. And using this spine to spline method, we can measure automatically scoliosis, and we see here a comparison of predictions relative to ground truth angle for different severity of scoliosis. And we validated our predictions against a set of 308 human angles. And we see that predictions for various severity of scoliosis corresponds to Pearson's correlations of above 90%. And these are scatter plots of on the left, automated versus the human predictions. There is a tendency of our method to underestimate the angle, which we try to fix currently. But our predictions are within 5-degree difference, as we see on the Blunt-Allman plot, using the 95% confidence interval. So we see that our predictions are relatively accurate, and given that humans do have an intervariability in measurements from 3 to 5 degrees. We do also have access to a second session a year apart. About 2,000 scans of patients have a second session. And since it is a year apart, we expect the spine curve to not vary that much, about a 1 degree difference on average. And we use this second session to validate our methods. And we expect those those points to be clustered around the zero mean. Now that we have the spine segmented and a measure of angle, what else can we measure automatically? We can also measure the curve location. So this is the location of the apex, whether it's cervicothoracic, thoracic, or thoracolumbar. And we did apply a dynamic threshold along the spine to identify the location. We can also measure the laterality, so the curve direction, whether it's right or left of the patient, and the number of curves, so 1 or 2 curves. And these are some descriptive statistics of the annotations we have that we can leverage and then apply on the 48,000 scans that we have access to. We have predominantly C-shaped curves, and then lumbar location, and predominance also of right curves. So this is, I think, typical of adult cohorts. So to summarize, we propose a robust geometric approach to evaluate spine deformities and to measure the maximum angle of the spine. But this is not limited to the angle of the spine. We can also measure curve patterns, which are the location, direction, and extent. And we hope to build a scoliosis phenotype to identify relevant predictors, stratify patients into subgroups in order to improve the treatment. And also, if we had scans at different time points, we could also predict how the curve would progress, and this could also improve the management of patients and propose more tailored treatments rather than invasive surgery. And if you have any questions, I'm happy to answer.
Thank you. Thanks very much. We'll take one question. Thanks.
Hi there, thanks very much. I'm Steve Morris from Bristol. I just wanted to ask about the clinical relevance of this and how we can apply it, because DEXA scans are performed in the supine position, and under physiological loading, the shape of the spine changes massively. So most of our patients coming through, if they're older, they've got degenerative curves, they don't get any problems when they're lying down. How can we then make it relevant? Because what you're suggesting is that we can use these DEXA scans to change our management. And if you're looking at people over 65, 50% of people have got a curve of some sort, and the vast majority never need anything doing about it. How will you work into that in the future?
So, yeah, you made a good point. And I think the methods, like its strength is that we can measure on like a continuous scale the severity of scoliosis. And if we know that most patients, they do have a curve, then we could adapt our methods to filter like the patients with more severe scoliosis or patients of interest. So we propose quantitative information that could be added to like the Cobb angle that's used mainly in clinics.
Okay, but it's worth bearing in mind that the Cobb angle will change massively when the patient stands up, and that's the thing that we use to plan surgery rather than a supine image.
Yes.
Only because we always have.
Yes.
Doesn't mean that's what we should do.
Exactly, but that's what I'm saying. How can we then move this on to make it relevant?
So this is absolutely fantastic work, well done, and really exciting. Just one question. You've done all your models on DEXA images so far. I presume your models would also be applicable to a normal standing X-ray or a supine X-ray?
Yes, we haven't tested an external data set yet, so it might need fine-tuning. So the good thing also about machine learning method is that once trained on the data set that's not too far from like X-ray, let's say we could be able to fine-tune on a smaller set of X-rays if we had annotation. We are not sure yet that it can be directly applicable to X-rays standing up, but there are some promises that it works already on DEXA from like different hospitals that we tried. So I think the method will stay the same, and the question is it robust to domain shifts and different modalities? And that would need to be further validated.
Okay, brilliant, thank you.
Thanks very much, thank you. So last talk, Fergus, please.
Hello everyone, Fergus McCabe is my name, ST6 from Ireland. I'm presenting research on collaboration with the Walton Centre. And our research question is out-of-hours decompression for acute disc herniation associated with greater perioperative complications. No disclosures. So as we all know, some acute lumbar disc herniations have emergent symptoms such as cauda equina syndrome that require emergency spine surgery. Surgery timing is a balance between trying to minimize the long-term sequelae of the problem versus the potential morbidity of out-of-hours operating. Many studies in both the orthopedic spine and general surgical literature state that there's greater morbidity and mortality with out-of-hours surgery. So we wish to assess if out-of-hours decompression for acute lumbar disc herniations is associated with greater frequency of complications, with secondary aims to see if out-of-hours operating led to greater revision surgery overall, and if cauda equina syndrome specifically had higher complication rates than other indications. This was a retrospective cohort study from the Walton Centre over a 2-year period. We included patients undergoing emergency decompression for acute lumbar disc herniations and excluded revision surgeries. Collated demographic, clinical and operative data. We defined out-of-hours surgery as between 8 p.m. and 8 a.m., so overnight. Patients were followed to at least 1 year, and our primary outcome measure was intraoperative complications, with secondary outcome measures being reoperations at 6 weeks and 1 year. So there was 344 sequential cases over the 2-year period. 50 years was the mean age with a slight female predominance. Cauda equina syndrome was the indication, 62%, with radicular leg pain and motor deficits being the other indications. In terms of out-of-hours operating, this occurred in 38%, with weekend but in-hours operating being 20%. The primary operator were registrars at nearly 80%, with consultant scrubbed 12% of cases. Single-level operations, mainly at L4, L5 and L5S1, were the main sites, and laminotomies, spinous process osteotomies consisted of the main operative techniques. In terms of intraoperative complications, there was a 10% rate, the vast majority being dural tears with a single root sleeve tear. You could see in terms of operative timing that actually proportionally in-hours operating had the highest complication rate, but they were relatively similar, not statistically different. Looking at the primary operator rate, consultants had the highest proportional complications, but again, they were relatively similar. On multiple variable analysis, operative timing was not an independent predictor of intraoperative complication, nor were any of the other assessed factors. With regards to reoperation, at 6 weeks, there was a 9% reoperation rate. Most of these were for persisting or symptom recurrence. But again, on logistic regression, there were no independent predictors, including operative timing. And a similar finding was found in reoperations at 1 year, 13%. And again, there was no specific independent predictors for reoperation at 1 year, including operative timing. So from this cohort, out-of-hours decompression is not associated with greater intraoperative complications or reoperation at 1 year. This study does not necessarily agree with 2 recently published retrospective cohorts where they both showed that there was greater complication rates intraoperatively with out-of-hours operating. They had slightly different definitions of what out-of-hours operating was, but simply put, our results just don't bear that out. Operative timing, particularly around Cauda equina syndrome, is a balancing act. As we've heard a lot of the new getting right first time pathway, it's between a category 1 and category 2 timing, and this is balancing against some other studies that say, such as Woodfield et al.'s prospective study, that operative timing might not have that much of a difference for these patients. So it's a continuous and constant balancing act. And we have to take into consideration that out-of-hours operating is not necessarily good for surgeons, though there might not be complications for your patient that night if you need to operate the following day. There is borne out greater surgical complications and personal risk to the surgeon, including greater needle stick injuries and car crashes home from work. So the strengths of this, it's a large comprehensive cohort, but it is limited by the fact that we didn't have data specifically on BMI or spoken status, which can influence complications. There may be some selection bias in the cases picked to be operated out of hours, but the direction of that bias didn't necessarily show that there was a difference, however. And of course, intraoperative complications are self-reported, but any major intraoperative complications, you would feel that they would probably be included on the operation note. So in summary, out-of-hours decompression for acute lumbar disc herniations is not associated with greater intraoperative complications or revision surgery. And notably, Cauda equina syndrome didn't show association with intraoperative complication than other indications. Thank you.
Thanks very much, Fergus. Any questions? Should take one.
Joe Surtees from NHS Highland. Did the out-of-hours decompressions happen at the same hospital, or did that require any transfer of care to another area?
No, they were all done in the Walton Centre. Yeah.
So the registrars were doing most of the surgeries, and they had less complication rates?
Not statistically, but on absolute terms, yes.
Sorry, go on. One last question.
Do you think it's, given that your specialist neuroscience centres, your theatre staff are very much used to neurosurgical operating, do you think it's generalisable to other places where the theatre staff overnight are generalists and don't normally do spinal surgery?
It's a very good point. Critically, team members knowing the equipment, particularly when you run into complications, is very important. but I just can't make that assessment. It's a well-made point, though, yeah.
Thanks very much. Virgos, thank you. We'll close this session.
Thank you all.
Thanks.
All right, hello everybody. I think we're running a little bit behind time. If you would like to find a seat. Right, so this next session is going to be Professor Jonathan Hill talking about digital health. He's going to be looking at digital technologies for managing non-specific low back pain with NICE's early value assessment and next steps. Professor Hill is a professor of physiotherapy at Keele University's School of Medicine, and his research focuses on improving the assessment and management of musculoskeletal pain. He's going to talk for 25 minutes, and then we'll have 5 minutes for questions afterwards. All right, so over to you, Jonathan.
Thank you very much, and thank you for all the organisers for inviting me. It's a pleasure to be here. There's a bit of a gear change, I think, in what I'm going to be presenting to what we've just been hearing. But I've been given this sort of title. I think Steve Vogel is the guilty person who persuaded me to this title. I'm going to do my best to talk about digital technologies and just also talk a little bit about what happened when NICE had an early value assessment of some of the digital therapeutics that are coming out. So there's 3 things I want to cover. I want to set some of the context, what's going on in the NHS at the moment. The second piece will be around digital therapeutics or self-management therapeutics. And then I'll be looking at the whole thing of the emerging area of digital triage and decision support tools for clinicians. So those are the 3 things. So if you go on the internet, this is what people say about why we need digital technologies, all the rising costs, the reducing quality of care, and the issues we've got with staffing. And that's not to mention all the sort of issues I've put in the green box along the bottom. And I wonder what you think is going on. We hear about it on the news all the time, don't we, about the NHS being broken and the problem particularly with primary and community care. And so I thought I'd just talk a little bit about that, giving you some data that is very hot off the press, and one of my PhD students, Alex, who's here, has been responsible for this. Alex has been looking at GP trends over 7 years for MSK conditions, and our ICS asked us, could we present the knee pain data for a piece of work the ICS is doing around knee pain and looking at resource allocation. So we haven't actually got the back pain work done, and this is hot off the press, but it really illustrates the issue. Now, this is all done as part of MIDAS, a big 5-year program of research that's just coming towards its end at Keele. It was a huge program with a massive team of people. But that has allowed us to do things like establish the code lists and to extract data at scale from general practice so that we can see what's going on for different sorts of conditions. So the data that Alex has been looking at, we've got 2 sort of cohorts where we've extracted from general practice. One where we've got survey data, baseline 3 months and 4 months, but only on 2,000. But we've got then a huge data set with over 370,000 MSK consultants looking over 7 years. So we can see, now the limitation of this is just from 30 GP practices local to us in Stoke-on-Trent. Yeah, and we all know the variation across the country. But it is giving us some insights, and I think it's helpful for helping us understand the context. We were asked just to look at the knee pain and over 45. You can see that knee pain is around 10%. If you add the under 45s and over 45s, it's probably the second most common MSK condition being seen, with backs obviously right up there as the first. So the first story is that over time, looking from 2016 to 2023, consultations are fairly static across these 30 GP practices for knee pain. There's not a big difference going on in terms of what you see in consultation rates. In terms of community referrals, fairly static as well. It goes up and down a bit in COVID, you can see, but roughly you're seeing about 14, 15, 16% of referrals off to community care, with physio being the big one. And some of the other things like escape pain or those other things that you might want to see, really, really very small percentages. One of the big things we are seeing, though, is secondary care referrals starting to increase. And we're certainly seeing that in the secondary care data, that in terms of the number of operations happening for this is just going up and the costs are going right up. So what's happening in terms of, am I in sync? Yeah, there's the secondary care referrals. Oh, sorry, yeah, I was just going to say the orthopedic referrals. So Alex has just looked at that, and we saw it's risen from 12% for back pain, the orthopedic referrals, to 23%. So for back pain, we're seeing a similar picture. It's not just knee pain, where we're seeing this going up over time. That's what's happening for medications, not a huge change, slight drop if anything. And this is what's happening in terms of imaging, with things like MRI and CT falling right off as they get switched off, and then X-rays starting to increase a little bit. And risk stratification, self-management, come on, it's not really coded, let's be honest. Certainly not happening for knee problems. I'd be interested to see, when we do the back pain, what's happening for the back pain. We do have a little AI project hoping to start once we get the governance, where we can look at the unstructured data using natural language processing, starting to look at this, because often that sort of thing, the GPs aren't coding, but they're putting it in the free text. And clearly, if you look at things like Startback, it's all about trying to, particularly for low risk, encourage that self-management support for the low-risk patients once you've done the red flag screen. So what are we saying in the context is? Well, the summary, I think, is the electronic health record data here, which is large, from these 30 practices, is essentially telling us a picture of everything relatively static, except for the secondary care referrals. Something is going right up in our secondary care referrals, and I wonder what you think is driving that. Interestingly, when you look at the survey data, pre and post-COVID, you see that patients are coming in a lot more severe, and their improvements are far less than they ever used to be. So, what we're doing for our society is not improving for our MSK patients. And when this comes to the commissioning, so back to the ICS, and what we're trying to do is use our figures to populate these sorts of things, where I've actually sort of shaded it off because I didn't think it was fair for me to show you that ICS's data. But you can see that you can actually add up all the numbers of how much we're spending in primary care and community care. And let me tell you, we're spending 26 million a year in our ICS on knee pain, just knee pain. 20 million of that is just going for knee replacement. And about 4 million of that is going for things like arthroscopy, MSK triage, MRI. And only 2 million is primary care and community care. And that the physio budget is 600K. And what you're seeing is more and more demand from the patients. That's one of the drivers. Yeah, so the patients don't want to be on the waiting list. They've pushed hard, so demand is going through for the secondary care. When they get through to see the orthopod, and he says, wait a few years, no, I don't want to be on the end of that 10-year waiting list. I'm going to push and have it now. So demand is going right up. And the other thing that people say is it's about sitting on risk. And as the GPs hand over to triage clinics, FCPs, paramedics, nurses who don't sit on the risk, then the referral rates also increase. So I don't know what your theory is, but those are the ones I'm hearing. So that's the context. Yeah, we're having to deal with, that is what is, in my view, breaking the NHS, is those sorts of things are what's going on. There's also this one other thing, and I just want to show you the practice variation. So this is knee patients, again, and the proportion getting a referral to T&O, but split by the 30 GP practices. And what Alex has helpfully done is he's put the practices into thirds across the IMD, so index of multiple deprivation. You can see sort of green is the least deprived. There are least deprived areas in Stoke-on-Trent. I know you might be surprised. But you can see that you can be in a nice leafy area and still you'll have problems. Yeah, or you might think it's great that you're getting the referral, but you can see that the spread. Other things like physio, going from 3% getting a referral in one GP practice right up to 23%, or 22%, I think it is, in some of the high referring practices. The one where we're seeing deprivation have a real influence is around opioid prescribing. Yeah, as you might expect from the more wealthy areas, far less opioids being prescribed. So that's the context. So where does the sort of digital fit with all of this? One idea, one solution we've got as a team, our vision is to stop this data invisibility in primary care and start making it routinely available for ICSs to have this data. We've got the ability to do it. We just need to get CSUs and ICSs working together to pull this data and look at it so we can see where the variation is, because there's a massive postcode lottery happening at the moment for patients, which isn't right, and we can see that we need to push back against the demand that's ever increasing. So dashboards, I think, are going to be a really important tool going forward. Now let's move to digital self-management, and I wonder what you think about apps and websites and whether self-management on its own is the solution. There's certainly an explosion of different products available. So I, among a big team, was invited as part of NICE's early value assessment at the end of 2023 to try and review what's the state of play at the moment. And so we were doing things like looking at Get You Better, stolen from, think you, Damien, thank you, this slide in the Birmingham Solly area. They've been piloting, rolling out Get You Better. Some of you might know Selfback. Selfback's got a clinical trial behind it. Selfback is trying to do sort of 3 things around rehab, exercises, education, and physical activity through step count. And there's been some trial evidence around Selfback. And then I was also involved in Supportback, which has come out of Southampton, very much an academic piece of work, trying to put together modules to make freely available for back pain patients the right information we'd want them to have. And when you look at the evidence, and I've just very quickly summarized the evidence between the Selfback trial and the Supportback trial, I think the bottom line message is probably in the purple at the bottom, where at 3 months, the difference on an RMDQ, something like when I went for the Startback trial, we were trying to get a difference of 2.5 between groups. You're seeing a difference of around 0.7, okay? So this is a very small effect, but it's a relatively cheap thing to deliver at scale, all right? So it's having a small effect, but it's relatively cheap. And I think the jury's out. Interestingly, the different trials came to slightly different conclusions just because of the slightly different ways in which they did their measurement. But what's the engagement? What proportion of patients? We've started to have a little team think about, we've pulled from the 2 different trials, trying to work out where next. And these are some of the things that came out of a recent conversation. Let's be honest about the engagement being relatively low. Let's be honest about the fact that they don't at the moment. These self-management apps are not addressing that issue of pushback and demand. Okay, they're not. The focus of the content isn't to reassure people to stay in primary and community care. Yeah, so they're not particularly addressing the issue, the context, the problem that we're all seeing in the NHS. They're also not being used by those underperforming GP practices where the variation is really different. Yeah, they're used in the other places where, everything's a little bit more, well, it hasn't all fallen over like it has in some GP practices where they're squabbling over contracts and they've got real issues, and we can see that in our data. They also miss the social support dimension that you might get on Strava or on Facebook, and they have very little behavior change aspects. So there's lots to be done to improve our self-management apps. The people are talking about maybe pairing experienced patient users with new patient users. Maybe that's a way to improve them, maybe through better monitoring, having things like shareable dashboards with the clinicians so that the patient knows that someone is looking at their engagement in their exercises and all that piece. So that's something that people are talking about. The Supportback experience that I did with Southampton has shown us that when you don't have medical device status, it's very difficult to get these things really rolled out and integrated into all the systems that you need to roll out. So definitely you need to be thinking about medical device status. Ideally, don't go for condition-specific like Selfback. You're far better with a Get You Better type piece because it's more generic, more implementable in primary care. Maybe there's some tailoring that needs to be happening, hybrid format of delivery. And clearly the new thing on the block is all these natural language processing skins on top, having, as we heard earlier, agents and this kind of thing where you can have a chat. And I know Versus Arthritis are trying to put together a project to curate where they have an AI that will curate their library of information. So you can say, I'm struggling with my sleep, and it finds the right information for you. So that's the sort of game changer that is coming very soon down the line.
I've talked a little bit about changing the trial outcome. I think we have to have non-inferiority trials and look for improvements in other areas than things like RMDQ, because I still think it's important that patients get information quickly and get the right information. And then there's the whole thing about the difficulty of implementation of this when you're relying on clinicians. The reality is clinicians are not very good at signposting. And when we match with digital triage tools, then you see the kind of the self-management piece goes right up, because there's a whole proportion of people who just automatically get signposted. So that's an interesting direction. So the NICE EVA recommended some things could be rolled out, some things couldn't, needed to stay for research, and it'll be interesting. There are a lot of different products on the block. So I've talked about the natural skins, the NLP skins that I see as the sort of the next thing for self-management that is on the block, and that's going to have to require a lot of research. So let me talk about now digital triage and decision support, because I think that has quite an opportunity to reverse the trends of demand that we're seeing. So there's been this explosion. You will have heard of these products. Some you'll know better than others. So EQL have got FEO Access, so Connect Health, 27 services around the country, all using FEO Access. It's huge. It's a digital chatbot. It's sort of a direct access kind of chatbot, and then it decides, and it sort of takes you through to this kind of thing where you can. It's doing the red flags as well as the self-management. And in Birmingham, where they're trying this, they're seeing about 10% of patients choose the self-management themselves. And that's what they want to do. But just jumping back to this one, so Physio Wizard actually went bust. Kirsten Lord's leading that, but I've heard they've just been taken over again. Quite an Oki Health focus. Dart again came through. Optima, Cabela Lowe, I examined her PhD a couple of weeks ago. The good thing about Dart is it's not trying to be too clever. It's not trying to put people into too many boxes, and that means it's short for patients. All right, it's really quick. It just does the sort of red flags, risk stratification, special questions, and it knows where to push people, but only into sort of some very basic categories. And then Flock Health, big study going on around Flock Health. That's the one everyone's really alarmed at. It's sort of huge AI and avatars. And then there's all the clinician-facing stuff. So cross-cover. Who here knows about cross-cover and orthopathways? Anyone? A few of you? Great. I mean, it's an interesting concept. So I'm just going to go a little bit into cross-cover as a sort of finish, because we've just done a trial of it. It's quite a cheap trial. It's not the world's best trial, but I'll show you what we've done. So cross-cover is a platform. It's a bit like YouTube. They provide the integration with EMIS and System 1 and the integration into the NHS app for the patient to see, the supported materials and all of that piece, and the PIFU and booking and all that sort of thing. But it's not their responsibility to build the algorithm. So we've been hearing a lot about Cord Requiner in the last session. You build a Cord Requiner pathway. That's not the company's job. That's the company of some clinicians where they've commissioned this by the ICS. So actually, Damien and a few other people, a GP, a rheumatologist, put together some key pathways. They kept the sort of difficult ones like fibromyalgia on the to-do list and went with stuff that was a little bit easier. And what they were trying to do was, this is just the back pain one, they were digitizing the pathway as to what questions they would want the GP or the FCP to ask, so that they would get that result of Cord Requiner Centre A&E, this one's self-management, Get You Better, this one physio, this one tier 2 physio, there's lots of complexity there, etc., etc. Does that make sense? So that's what they built, and what it does is it gives you the decision output. On the right-hand side, you get all the decision summary, right? No red flags, start back, medium risk. Therefore, it's a back pain pathway with referral to physio. Give them Get You Better. Go for NSAIDs. If they're contraindicated, you can use weak opioids. It gives you some basic information about what you need to do in that first-line decision. So it's all about trying to get best practice done at the front door. And what the GPs told us is when they use it, they can push back. The patient's going, I want that scan, I want that referral. Well, the computer doesn't think you need it just yet, I'm afraid. And they said it was wonderful. They got to just push back against what the patients were asking for.
because of the decision support tool that was at their fingertips. So we did the trial. I won't be able to go through the whole thing. It was only SBRI funding, so it wasn't like a big HTA or anything yet. But we did a pragmatic cluster trial, 19 GP practices. We were able to pull the data just for 3 months. Well, we went live for 3 months, and we had 3 months worth of data for every person who was a new patient with MSK or a new presentation of MSK within that period. And then we looked at the 3 months of the intervention versus the control, just on decision making. And we had about 10,000 patients, just over 10,000, where we pulled the data. It didn't quite work equally. There was about 6,000 versus 4,000 in either arm. But we were able to see that the engagement from the GPs was pretty low. Yeah, only 8% were using it. It was a few individuals who made the change. Most weren't. They've got such algorithm fatigue, haven't they, the poor GPs? Not another algorithm study, please. But where this is going is you can build multiple algorithms, for eye problems, respiratory problems, cardiac problems. This cross-cover product isn't in any way limited, and it's very adaptable. You can change it. Like when the Cauda equina guidance came out, Damien's team had got it changed in like 10 days and implemented to every GP practice. You can see that the primary outcome was actually inappropriate care. And I'll show you how I did that in a minute. It was our primary outcome. I didn't want to just do bean counting that we've done again and again. It increased self-management information. It significantly reduced routine referrals to secondary care, which was, I guess, what they were wanting it to do. And it increased referrals to community care, so it kind of did exactly what they were hoping it would do as a study. So in terms of decision-making, it's looking quite effective. So what was the primary outcome? Let me just show you. So Alex, again, who's here, has been doing work on quality indicators. And he'd done a systematic review. As a team, we went through and pulled out ones we knew we could feasibly pull out from the electronic health record. And we got a list of 12 rules. And essentially, as a team, we decided on these 12 rules before we looked at any data at all. And some of them are prescribing. So things like NSAIDs being given without gastroprotection, long-term opioids, neuromodulators when there's no neuropathic pain, missed opportunities around repeat visits 3 times and not getting anything other than medication, fit notes 3 times and not getting any tests, referral, anything done, and then sort of poor practices around imaging or urgent referrals. Now, where the intervention had an impact was actually just in 2 areas. All right, it was around the missed opportunities and it was around the off-protocol imaging for MRI. And so that's the kind of key areas, but where they are already trying to adapt things is so that they don't have like the missed opportunities around the fit notes and all that sort of stuff, because we've got to get better quality primary care. It was significant. It significantly reduced inappropriate care by about a half. And we had to do this via clinical review, so we had to randomly pull 120 of the 10,000 patients and do a fairly painstaking clinical review. Lovely if we could get machine learning in the future to do it for us, but we're not there yet. So engagement was the issue. Thankfully, it was better than I did a trial in Norway on a decision support tool last year, and the GPs just didn't use it. It was less than 2 minutes. The patient had left the room before they just completed it for the sake of the trial. Here, at least we were seeing when it was used, they were engaged. They only opted out 5% of the time from the recommendation of the decision support. So some really positive signs from what we're seeing. And it reduced cost by 10%, reduced carbon by 18%. It did have some real limitations, this trial. I'd love to do it bigger and better in the future. So we are trying to think about how we could do that. And for sake of time, I'll just stop very soon. I'll just say I think the next steps are probably around merging the sort of chatbot interface at the very front end with a clinician decision support tool. So those sorts of bringing together of those technologies has got real legs. And I also think, the ambient voice technology thing is taking over the private physio world. It hasn't quite got the NHS yet. But, what people are talking about is if you've got a decision support tool, let's say around red flag screening, the ambient voice will listen and go, prompt you, you've missed this question that you really ought to have asked. Yeah, so that's the sort of direction. Whether we want it, I don't know. But that's where the technology people are already starting to think about going. Why am I excited about the decision support? Because I do think it is able to push back against all those rising trends and costs and the big issue we've got. And somehow we've got to support our ICSs to get primary care, to stop it falling over, to get some of the resource back at the front end. Yeah, because it's just shocking where we've ended up at the moment with where all of our spend is because of the patient demand and push. And we need to somehow serve our society better. There's, literally thousands of knee pain patients, sort of 20,000, and yet only 2,000 are going to get a surgical operation. And yet that spend, is just unbelievably tenfold greater, if not more than the primary care end. So lots to do. I'm going to stop there. Hopefully, there's my summary. Hopefully that's been interesting to you, and thank you for having me.
Thank you, Jonathan. Does anyone have any questions? I have one question for you in the meantime. Just you mentioned this algorithm fatigue, and just the really low uptake in clinical settings where there's real potential for this to support clinicians and actually reduce their workload. What do you think are strategies we could use in the future to increase that?
Yeah, that's a great question. We did see, we had FCPs and paramedics and nurses using the decision support tool, that they are keener than the GPs. So there is a difference. And one of the things that we saw was where you've got some of the FCPs have come out of area. There's been a number of Indians that have come to work as FCPs. They've got the clinical knowledge, but they don't know the NHS system very well. They absolutely love the decision support tool because it kind of automates the referrals. It checks, all of that eligibility criteria. So if you're out of area coming in as a clinician, can you imagine how helpful the decision support tool is? Whereas if you're kind of dyed in the wool, you've been working there 20 years as a GP, do you really want some algorithm to tell you where to send this next patient and to distract you from the eye contact? Of course you don't. So, I think there is a balance, and we certainly don't want intrusive technologies that reduce, that kind of patient communication between the doctor and the patient. So it's finding the sweet spot where this assists but isn't intrusive is the real challenge, I think.
Thank you, Jonathan. I think from the interest of time, we'll have to let you catch up in the break, if that's okay. Thank you. Thanks again.
So, next speaker, Peter Sullivan.
Hi. So I'm talking a bit about back pain, and particularly around a clinical trial that we were involved in running. So what do we know about people's experience of back pain and health? Well, it's pretty dire if you look at the stories of people who suffer from back pain. They describe the experience of healthcare, of being told that they've been damaged, of becoming distressed, of becoming disabled, feeling stigmatised and invalidated. They describe the psychosocial impact that pain has on them, where pain becomes scary and threatening, unpredictable, and they become fearful. This uncertainty for the future and this loss of identity. And then coping with pain becomes this process of hypervigilance, protection, avoidance, and reliance on medications that often don't work well. And then strategies to control pain become social withdrawal and a juggling act between acceptance, pushing through, then linked to often despair. And I suppose the question is, can we do better than that? Because that's a pretty bleak view. So if we think about what puts someone at risk who develops back pain becoming chronic, then there are a number of studies that highlight that interactions in healthcare are a bit of an issue, and that the messaging that we give people is a problem. And so when patients develop a view that their pain is linked to being damaged, that might be reinforced by an MRI scan, that it's caused by some kind of injury that will result in disability, might not get better, the strategies that they use don't work, it can obviously make them frightened and distressed, and it can impact on their mood when they start losing the things in life that give them value. And often this reinforced by things that are advice that people are given around, rest over protection, avoidance, reliance on passive therapies that kind of set up this vicious cycle of this negative mindset, distress, and unhelpful coping behaviours that lead to pain persistence and disability. And of course, we know longitudinal studies show that people just get stuck for years on these kind of trajectories, which seem really hard to shift. And we look at the kind of care options that often occur with people with pain. Or if they're not getting better, often they get imaging and they get told the kind of scary information that might come from a scan. There's a lot of often passive therapies, reliance on drugs that don't work well, interventions that we know can maybe give short-term pain relief or are no more effective than non-surgical interventions. So there's a real need for effective interventions that can help people with back pain. So what do patients want? Well, they're pretty clear that they want to be listened to and validated, and they want to work with us in partnership. They do want a diagnosis, but in the absence of a diagnosis, they want to know what's contributing to their pain, and they want to know about the future consequences. They want a plan. They want a plan for recovery, they want control over pain, they want to get functioning, and they want their quality of life back. So it's not just a pain thing, it's a much bigger story around their life. So we've tested this model of care, which we call cognitive functional therapy. It's a kind of whole person approach, person-centered care around a clinician coaching the patient to learn to adequately self-manage their problem. There are three core components. One is this kind of making sense process of, in the absence of a clear diagnosis, going, what are the contributing factors to that problem? The second part is coaching people to develop confidence in their body to get back to the things in life that they value, and then targeting lifestyle-related factors where it's appropriate. It's person-centered, it's aligned to the guidelines, it's targeted and individualized to the presentation of the patient, and it doesn't take a lot of care. So essentially, patients are weaned off seeing the patient is weaned off the care as they are taught to self-manage. So up to around 6 to 8 sessions over 12 weeks, and in this trial we tested a booster session down the track. Person-centered care is central to this intervention. So listening, respecting, responding to the person's needs, concerns and preferences, ensuring they are heard, validated and valued is critical. In terms of the interview, then exploring all of these different factors that we know are important. The person's beliefs, their emotional responses to pain, patterns of avoidance and protection, their goals, the things that they want to get back to, issues around their lifestyle and their social setting. And then within the examination, we explore the things they can't do, the things that they're frightened of, or the things that are obstacles to them regaining independence and getting function back. And then we look to see if we can give them strategies that invalidate their beliefs or violate their expectations. So build a sense of safety back into the body. So underpinning this is a clinical reasoning framework, which kind of looks to all the different potential factors that might be a driver to that person's ongoing pain and disability. Issues around avoidance behaviours, overprotection, issues around their social setting, pain cognitions, pain-related emotions, tissue-sensitive profiles. Of course, we screen for pathology, issues around comorbid health-related problems, and lifestyle factors. And based on that, we will identify the contributing factors for that person and target them in a person-centered way. So the making sense bit is to develop this person-centered understanding. So we take literally the story of the person within the examination and kind of create a formulation that makes sense to them. So it's very personalised. cognitive reassurance, identifying the main concerns and then specifically targeting them in terms of the way that we communicate. Exploring new responses to the way that they engage with the world and creating a positive mindset, goal setting, and then pain exacerbation plans, because often it's the pain exacerbations that really freak the patients out. It's like giving them strategies to effectively manage those pain exacerbations. And then there's this kind of journey of building confidence back, of targeting the things that the person fears or is painful or they avoid, of building confidence, reassurance, giving them strategies to re-engage with movement and activity, to give them a sense of safety back in their body. And then immediately generalizing that so that they can get back to the things that they value to reduce the sense of threat, build their self-efficacy, get them strong and fit for the task, and then chase their goal. So it's entirely goal-orientated. And then finally, re-engaging in healthy lifestyle behaviours around engaging in physical activity based on their preference, giving them strategies to manage their sleep or around stress as well. So this intervention was tested in the RESTORE trial, which was published in The Lancet a couple of years ago. So Peter Kent was the lead author on this trial. It was a two-centre trial, so we trained up 18 physiotherapists across 2 centres that had minimal experience in this exposure to this. They had about 2 years of experience. They weren't handpicked. They went through a basic training program, which I'll kind of talk to, over a few weeks, a number of months. We're seen once a month over a period of months around building their knowledge, basic skill, communication skills. It was a bit of a mind shift for the physios because it's a different way of working as a coach, not as a treater, and then some direct mentoring where they were working with people with back pain. And then we created a competency standard, so they weren't allowed to go into the trial until they demonstrated that they were able to perform the intervention as it was designed. So this kind of process of like training knowledge, skills, competencies while they work with patients, and then we kind of had this checkpoint where we went, yep, you can go into the trial, or you've got to wait still until you hit that point. So the physios who went through this described this interesting process. They said there were these pre-training factors of this willingness to learn and change and confront their own beliefs and behaviours. And then this kind of journey where they actually had to learn through their own exposure of the things they said and the way they behaved that they didn't even know that they were doing. They're signalling to people to be careful with their back and protect their back, and often it exposed their own fears around getting people to re-engage in movement when it was distressing the patient or it was painful for them. They said there were some roadblocks around physiotherapy culture where people were going, what the hell are you doing? This is crazy. You know, you're not teaching people to protect their back when they lift and just relax their bodies and use it naturally. They thought that was pretty weird. And then this process of saying, you know, they developed this confidence but not mastery of engaging with people who are distressed and frightened to work with them in a new way. So who were in the trial? There were about 500 people with chronic low back pain in the trial that had pain for about 4 years on average. We included older people. There was no upper limit because often older people with back pain are excluded from clinical trials. We included, specifically had a very open inclusion criteria, so they were probably more disabled than most clinical trials. We included patients post-surgery, people with mental health and other health comorbidities. Many of these patients had literally just given up on care. They were sitting in the community, disabled and distressed. So with 3 treatment arms, it was the CFT only. We had another group that used movement biofeedback to see if that would augment the effect that was given feedback around the way the patients moved. And that was compared to usual care. Now, usual care wasn't no care. There were a lot of people on medication, and around 70% of people sought care for their back pain over a period of 12 months of any variety, whatever their referring practitioner or who they sought out. So in terms of the primary outcome, which was pain-related disability, you can see in the blue that was the usual care arm, and the 2 CFT arms, sensor biofeedback and without, showed a very similar pattern of reduction in terms of pain-related disability, both at 3 months and 12 months later. So in terms of clinically important difference, about 70% of people at 12 months hit that level versus around 24% in the usual care arm. So in terms of pain intensity, we saw a similar pattern where about 50% of people at 12 months were reporting a clinically significant improvement versus 25% in the usual care arm. In terms of secondary measures, patient-specific functions showed the same effect. Pain self-efficacy, pain catastrophizing, and pain-related fear were all significantly shifted. So all the things that we were specifically targeting into the intervention all shifted in the same direction, which gave us some confidence that the intervention was actually doing the things that we were hoping for. In terms of cost efficiencies, the CFT arm was associated with over $5,000 of savings for the people who went through the CFT treatment arm, and that was related to getting back to work. So these people were getting back to work, and so there were significant cost savings. And importantly, people liked it. And we'll talk a little bit about the qualitative data in this as well, that they were satisfied, and they were highly satisfied with the treatment. Interestingly, there are so many messages for people to protect their backs with back pain. And one of the reasons, the pushbacks we get is like, it's dangerous to tell people to round their back and pick things up. You should be lifted with a straight back and brace your core. We explicitly taught people not to do that. We explicitly told them it's okay to relax, to slouch the back, to bend, to move. It's safe to move. You want to build trust in your body and not protect it. We saw no adverse events in that group. And that's important for us because there's a lot of beliefs around backs that need to be protected. There was no additional benefit from the biofeedback. Now, Mark Hancock published this moderation analysis to kind of look at the people we did or didn't help in the trial, and you can see that the biggest effect was in the most disabled group. And look, obviously there's a kind of bottom effect here where you can't get a large effect if you start at 2. But the thing that's helpful in our mind at this is that we were helping the most disabled people in our community. And it's often those are the people we struggle to help. Also of interest is that other factors like pain catastrophizing or pain-related fear or pain self-efficacy or pain intensity weren't moderated. So it didn't matter at what level you were at with those other measures, the intervention looked like it was working. And that probably makes sense in terms of the personalised nature of the intervention. So how did it work? So the mediation analysis, this is under review at the moment, looked at what explained the reduction in disability in the CFT arm versus the usual care arm. What changed in those people? A reduction in pain was one of them, and we explicitly target pain reduction within the intervention. And that's something often is given up on with people with chronic pain, is a belief that you can't change pain. Pain changed, and it looked like it was important. When that changed, it explained some of the effects. A reduction in pain catastrophizing, so they had less of these catastrophic thoughts. They were less frightened, and they had greater confidence to engage with things. And these are all the things that we were targeting in the intervention. That explained about 60% of the effect. In terms of explanation for why they had less pain itself, we saw a similar pattern. So that when they were thinking less catastrophic thoughts, they were less frightened, had greater confidence, that explained the reduction in pain. Now, it doesn't explain everything, but it explains a pretty decent chunk of the effect. We were able to also look at how people moved, and this is interesting. There's very little movement data in people with back pain. All of you know that when you see a patient who might present in your clinic, there's something about the way they move. They often move slower, they're more guarded, they're more protective, they might prop off their hands in the way they move. They're not moving freely. So we were able to capture at every treatment session within the CFT arms movements. And so I'll just show you, say forward bending, for example, was one of the movements that we captured. So here you can see on one side a reduction in pain intensity and disability, and this is trunk velocity and trunk range of movement. So as people get better, they move quicker, and they generally move further. So they're less guarded, they're less protective around the way they move. And this data was published. Ruth Chang published this just recently in the Journal of Orthopedic Sports Physical Therapy. If you just look at these two people, pre and post, you see a big difference in the speed of movement. Very slow and guarded of the person on the left, same person on the right, way quicker and fluid in the way that person moves. So what she was able to show in her data, so this was collected longitudinally over each treatment session, that as people had less pain and disability, that was strongly correlated with an increase in movement velocity. So they started moving faster, and they often moved further. She's also just had a paper that's just been in press that's shown a relationship between the speed of movement and things like pain catastrophizing and pain self-efficacy. As a person's more confident, they re-engage with movement faster. And so these movement factors that we explicitly target in the treatment look like they're important, relating to some of these cognitive factors as well as clinical outcomes. And this kind of makes sense if we look at some of the qualitative work that we've done, that patients often describe being in pain and feeling like they have to consciously protect their back, and then subconsciously this kind of stiffness and tension and spasm that they feel in their body. And through the journey of CFT, we explicitly teach them to relax their bodies and re-engage with movement in a normal and confident and free way. So we push them to move fast. We push them to re-engage in a non-protective way. So this kind of conscious non-protection then becomes like a subconscious non-protection of re-engaging with the world again. This is data that's under review at the moment. Mark Hancock led this analysis, which looked at three-year outcome data, demonstrating that the clinical effects have lasted out to 3 years. And this is for pain-related disability, and the same thing for pain intensity. So that excites us because explicitly this is targeting behaviour change. This is targeting people to build self-management strategies in these patients so that they have autonomy to take care of their own world and not rely on healthcare. So what did the patients think? So this was an interesting qualitative study led by my colleague Nadia Clem. And these interviews were conducted before the intervention started, then during the intervention, at the end of the intervention, and then 12 months later. And this has just recently been published. So before the intervention began, these patients described this process of being left high and dry. They felt stranded by health professionals. They felt they weren't listened to, they were invalidated. They had a feeling of being stuck, unsure on how to move forward. They had stories of being told they were damaged, of avoidance and fear that were often related to the things they've been told. So really similar to this, the qualitative synthesis I talked about earlier. They describe this process of their worlds becoming smaller. So just a couple of quotes. Living but not living. It's like being in a shell, protecting. Scary. I was concerned that if I didn't watch what I was doing, I could damage the spinal cord or some of those things. So these people are frightened and avoidant and protecting. So she described three kind of themes that emerged. There's one group that was just like smooth sailing. The therapeutic relationship was critical. They had this reconceptualization of pain. They had this concept that it was safe to move again, this understanding the need to relax and move and strengthen the body and re-engage to get back to living. And so this idea of like just some of these, unhelpful beliefs. There might be a bulge there, but I realise that anyone can have a bulge. But if the more you tense your back, it's keeping the back straight. So I'm just bending now. So this kind of, these beliefs and these behaviours got switched. It's like I'm not frightened of these findings on my MRI scan. The second group was harder. They kind of talked about this tough process of like learning the ropes to get these sea legs. So the therapy relationship was much more important here. It's like building trust, this trust in the clinician to do scary stuff. This continual learning process of building mastery around feared movements, the importance of practice and repeated to build successful experiences, and then negotiating setbacks. So when they have a flare-up, knowing how to manage it to build confidence. So this person says, I think it's important to be able to be shown if you do something that you may be a little scared of doing and you do it and it's fine, there's obviously going to feel much more confident doing it in the future. So this is around that in vivo experience of engaging in scary movements and activities. And the last one was around sailing through headwinds. These are people who found it really tough. So that, again, the therapeutic relationship was really important. This reconceptualization of pain not being damaged was difficult for them. There were lots of headwinds around learning to adequately self-manage. And some of that really, one of the people here was like 86, so she was really struggling around that, struggles with self-efficacy, difficulty managing flare-ups, and the need for ongoing support. And so, it's not all done for some of these people. They need some kind of transition to some kind of ongoing, maybe community groups to just help support them. So there was just recently a systematic review of CFT and about 8 clinical trials that have been conducted. And there was one negative trial, and this was with a single clinician that delivered the intervention, who was a new graduate. And so it looks like the training's really important, that training clinicians to a level of competency. It's not just, do a workshop and off you go. It actually takes mentoring. And the trials that showed large effects, the training seemed to be the key. So the conclusion of that trial was that this is a promising intervention for helping people with chronic low back pain in terms of reducing disability, pain, and building self-efficacy. There's just been a sham-controlled trial that's just been published in BJSM demonstrating, compared to a sham, that the intervention has large effects. So it's not just nice people chatting to someone, because that was part of the sham. So there are lots of roadblocks to this kind of intervention. Some of these are with clinicians, and in terms of our own role and identity, our own skills and our own behaviours, the way we communicate with people, and also our care environment, do we have the support? Also with patients, there's a mind switch to not being the recipient of care, actually being taught to be in control. And a lot of the patients describe this as like to go to a physio and actually be coached was quite a different thought than lying on a bed and having stuff done to them. So that was tough. We also heard the stories of people with really difficult social situations, health comorbidities, mental health challenges, where the need for co-care was important. It was not enough just for the physio to be doing the work. Then we got massive issues in Australia around health system, and we obviously heard about that with Jonathan around health funding, that we're funding really, really expensive interventions that don't have great efficacy, and we're not funding and supporting low-risk interventions that actually help people to self-manage. We got issues around time, because communicating with people takes time, coaching people takes time, and we've got a health system with really contradictory messages, where patients get told one thing and they get told another thing. We need unified messages. And then we have expectations in society, like Jonathan mentioned, of I've got a back problem, I need an MRI scan, I've got a degenerative disc, I've got to have it fixed. So this belief that the back is like a machine and somehow it's going to be easily sorted, which of course we know it isn't. So where does that leave us? Then I think I'm hopeful around we can do better with people with back pain. We saw that in the Restore trial. We're running a number of implementation studies. We're seeing these results repeated in different care settings, in different countries, in primary care and secondary care. But we've got a huge job of educating the community that actually this model of care is actually good for their whole health. It gets them back to living again. It puts them in charge. There's a job of upskilling people, and we think this kind of model care should be brought into early education, that we should be supporting these, developing different kinds of skills that we've been traditionally supported. And so we've got initiatives around kind of building capacity and training in clinicians to deliver this care. And then we have a system problem around where we divert resources. Again, what Jonathan talked about, we're massively underfunding this kind of model of care and overfunding other care. So we need to do that. Of course, we're involved in lots of further studies to go, can we do this better? Can we provide online online training? Can we adopt this to different cultural settings? Can we integrate this care to work with other health professionals, with people with health comorbidities? And of course, can we deliver this intervention beyond the back? And we're involved in other studies looking at other chronic pain problems, not just back pain, because the model of care makes sense for pain. It's a good health model. And just a plug to my colleagues, I think Chris and Gurpreet and George are presenting some of their work of application of CFT within the NHS tomorrow morning. So go and listen to them. They're doing some really cool work in tough communities with underprivileged people. Now, we have a bunch of implementation strategies. So if you're interested in this work, you can go to our website, restorebackpain.com. We'll be launching a social enterprise soon, which is to create opportunities for equitable access to knowledge to support clinician training, hopefully in the next few months. So finally, massive thank you to our team. I work with some extraordinary people. I'm one small piece of a big cog, and Peter Kent, who led this, did an extraordinary job pulling this whole trial together. And we're involved in a lot of other research beyond that too. So thank you.
Thanks a million, Peter, for coming all the way from Australia to share your research and insights. We're open for some questions. First question from myself is could you just expand a little bit on how this approach can be applied to the UK's services, and what start has it started to be made?
Yeah, so probably a few different things here. So Chris Newton did a feasibility trial of CFT in the NHS. It was published a couple of years ago, I think, demonstrating really similar effects and good acceptability. We've just done an implementation, like training a group of clinicians up in Glasgow in Scotland, within the NHS. And so the person who came to us was saying, we've got this huge burden of people who are really disabled, and we've got a workforce who are really demoralised. They don't know how to support them. And so we've taken a group of those people, and Gurpreet and Ian Cow were involved in supporting that training process within that group of clinicians. And the qualitative kind of response is this renewed joy of work, of this confidence to work with people, and this kind of building clinical self-efficacy. Is often the clinician doesn't have self-efficacy, they can make a difference. So there's no way that's going to change. So that gives us a pretty strong indicator that this intervention is appropriate and going to work in different care settings. We're also doing implementation research up in Denmark, and that's a public care setting as well. So we're very interested in how this approach works in different care settings, and it looks like it makes sense for your care settings.
Yeah, that's good to hear. And I think, and just to back that up, and Jonathan's stuff, at present, physios have been pushed into do triage services, and we're rehab specialists. And if we can push the digital stuff, maybe we'll have more time to do this stuff.
Yeah, and I kind of look at that digital space in terms of, like Jonathan said, there are people who don't need a lot of care, but there are a lot of people who do need care. We should be targeting them because they're not living, they're not working, they're distressed, and there's a whole burden beyond back pain that they carry that we need to help them with.
Thank you very much, Tim German. I'm a spinal neurosurgeon in Plymouth. That was a really interesting talk, and I actually found it very encouraging. Thank you.
Thank you. In
my job, a spine surgeon, the vast majority of people that I see, their primary complaint is pain. Probably 40, maybe 50% of the people I see, I cannot explain their pain. So for me, that goes into the unexplained symptom box.
Yeah.
It's in the supratentorial space. The problem is, how do you manage that?
Yeah.
And I think the model that you're describing is the logical sort of service to seek. All makes sense to me.
Yeah.
I think you could expand it, as you implied, to unexplained symptoms, all unexplained symptoms in principle, which is a huge problem for the Western world.
Yeah.
I think what might be possibly missing a little bit is the the sort of psychiatric input, because I think what is the relationship between what comes first, a poor mood? Does that precipitate the pain, or does, is it a chicken and egg type thing? So I don't know how much you may have looked at.
So that's something we're interested in as well. And the research would say there's a bidirectional relationship between, as you know, between mental health and pain. So we know that some people don't have a prior mental health problem. They develop pain, they become disabled, they become distressed and frightened, and then they develop one, where others it's pre-morbid. And so trying to tease that out is key. We're also doing work at the moment of working at a co-care model for people where they do have comorbid mental health. So we're working with a psychologist working in tandem with the physiotherapist to kind of support that patient, and obviously including the GP as well where it's appropriate. So this is a model we've tested. But in saying that, we saw there were some very distressed and disabled people in this trial who got better. But we know 30% didn't hit, in terms of disability, there were 30% we didn't reach, and we're really interested in that group to see whether we can develop co-models of co-care that can better support them, which is probably what you're highlighting.
Yeah, well, I think a pain, as a disabling pain that you can't explain, is a fairly sensitive indicator of underlying poor mental health, and that is the main problem. So that's my concern there. The other thing is a slight concern. On your slide, you said that doing MRI scans leads to ineffective and expensive care.
It can do.
That may or may not be true. I know the literature pretty well. I don't think there's any literature that can support that. And then on the multi-dimensional chart that you had, you had pathoanatomy.
Yeah.
Well, for me, the only way you can say that person doesn't have a structural cause to their pain is an MRI scan. An MRI scan is actually cheap. Might not be in Australia because the radiologists get paid so much, I don't know, but it's a cheap investigation, it's a safe investigation, and if you get a completely normal MRI scan, I think it's unbelievably helpful.
Yeah, so I accept that. There's pretty strong evidence that how an MRI is communicated can have a very impactful effect on a patient, though. And I think the key there is not the MRI, it's the communication of the findings. And I think there's irrefutable evidence for that. And so we have to be careful. I mean, these people, as of the qualitative studies, have had MRI findings of a degenerate disc or, fissures or whatever, and been told their back is damaged, that have left them frightened and distressed. So we can't be doing that to people.
No, you just tell them it's like grey hair.
Yeah, exactly. But that sadly is not happening.
No. Anyway, thank you very much.
Yeah, pleasure. Thanks.
Thank you all. I'd just like to encourage everybody to attend Peter's keynote speech, 4:45 in the main auditorium. Thanks to both speakers.
Bring a drink.
See you later.